For you newcomers, you beginners, you do not have to understand everything that was said here this weekend. Okay? I don't understand most. Some of the stuff that we were presented with, I was like, huh? Okay? So you do not have to understand that stuff. I was just talking to a lovely lady out in the hall. Keto's low carb, proper human diet, whatever you want to call it, it's easy. It's meat and eggs, it's meat and veg. Literally, that's it. Okay, you don't have to understand any of the science. You actually don't have to get any labs checked whatsoever to be 100% successful with this way of eating and to attain all your health goals. Just wanted to say that, put that out there. Because I could see some deer in the headlights. Like, oh God, I don't understand any of this. I guess I can't do keto. You can do this. You do not need to understand any of that stuff. When in doubt, meat and eggs. When in doubt, meat and meat. When in doubt, meat and a little veg. Boom, that's it. You're done. Okay?
I don't know, Ken. Until I learned about how gravity worked, I was falling up.
You kept falling up into the sky until you understood the law of gravity. Right.
Let me say, one of the great things is when the lectures go on YouTube, I mean, ones I don't understand, after the fifth time, it gets a little bit more understandable, which is a great opportunity, too.
So I am a newbie and just NTA certified, but one topic that has not been mentioned at all in any of the discussions that I'm very interested in is gastric bypass. I am a gastric bypass recipient from 2004. My passion is to work with those who are seeking that and help them to not, or either those who have and have nutrient deprivation. I never know what the formula is for someone with a gastric bypass. I was very successful at that with it. I do have a little bit. I have gained a little. I am in that process of going back down, but I know that it's a lifesaver for many people. So that's a personal decision. But how much meat? I mean, I'm more carnivore, keto carnivore, but I think I would just be curious to see what your opinions, what your medical advice would be to maintain health moving forward, and for those who I may be working with nutritionally.
Just a small comment, there will be no medical advice given on this panel.
So, yeah, unfortunately, Rob couldn't stay, as obviously he's the expert. But, you know, my perspective on post-gastric bypass patients is the diet doesn't really change. You know, you eat the same foods. You can't eat the same amounts. You might have to eat more often. And you do have to be cognizant, depending on the type of surgery that was done, that there is going to be malabsorption. That's what the surgery is designed to do. So you have to keep an eye on the supplements and make sure, you know, you're getting enough of the vitamins and minerals. But for people who are post-gastric bypass that want to do this, it's the same diet. It just, you know, you might have to make little tweaks. And certainly I would encourage anyone that's considering gastric bypass to try this first. But, you know, obviously many people have had gastric bypass. Both my parents had gastric bypass, as full disclosure, and now they're many years out from that, and they kind of do this, mostly do this, and they just have to modify. They can't eat, you know, they're not going to be OMAD, but they can do the same type of diet, just with more frequent, smaller meals.
Yeah, I see a lot of these patients in my clinic, pre and post. I could put it in the Dropbox. There's a really good article called Medical Management of Gastric Bypass, because there's a big difference between the Roux-en-Y and duodenal switches, where you actually take the small intestine out, which is a massive absorptive surface, versus the gastric sleeve. And I have to pull this paper out every time because it has like a checklist of what labs based on the surgery that you have to be on top of. The people who've had a Roux-en-Y duodenal switch, basically they don't have small intestine. You know, there's like iron, there's B12, there's thiamine, there's folate, there's thyroid, there's PTH, calcium. I mean, so these folks end up being malnourished, the ones who actually have their small intestine. Not much different scenario than someone who's having a gastric sleeve or banding. So the draconianness of that is operation is much different than the true bypasses. And as Rob Sivas would testify, is, you know, they have to fix their brain, you know, so there's so much food addiction that's going on prior to that. So working with these people, I just saw a patient last week who's a wonderful success story after a gastric bypass. She's lost about 150 pounds, kept it off. She couldn't, her knees and hips were so bad, and she had lost 40 pounds before the gastric bypass, eating the way we describe. And I saw her back, and she's doing wonderful. And I think I said I'd support you in this choice, because I don't think she would have really been able to overcome what she was overcoming, and she feels good about herself now. Now we need to get her a paniculectomy covered by insurance. You know, she maintains it for another 6 months. That's where they get the skin and working through insurance. But it's medical management of look up. You have to pull this paper up, because they need ADEK vitamins. I mean, you can't just wing it. It's a very specific checklist, what vitamins they need, what labs to do, what to do if the labs are off. But it's very intense after a gastric bypass. These people are medical patients for life.
Thank you.
And if they can do it without the gastric bypass,
I will
then
email
they're
you
good.
to get that, but I did have the Roux-en-Y, and the doctors literally, when you leave, they say, don't drink out of a straw, eat your protein first, and don't drink carbonation. That was basically the advice that I
there's
get.
tons
So
of
anyway,
vitamins
thank you
that
for.
you need. Yes, I'll share the article.
Yeah, okay, so it turns out I can't count, amongst other things. Don't you just want to shift down a little bit? We need to fit Ben on here. All right, I'm sorry about that. Oh, yes, and I think it was me that was causing that feedback.
Oh, well, one thing, I have very little experience with patients post-Roux-en-Y or gastric bypass, but the physiology is very interesting, and I've read a bunch of the literature. As far as reversing diabetes, the gastric bypass is much better, certainly than just when you restrict the size of the stomach, either with, less experience with the sleeve now, but you're certainly bypassing at least most of the proximal small intestine. It causes all the poor absorption, malabsorption syndromes, which are really important, but you're also bypassing GIP. The incretins are very important. And if you're having processed carbs, white bread, the absorption is proximal small intestine, stimulating GIP. It's called the incretin effect. That goes to the pancreas, and you produce a much higher insulin spike than if you gave the same glucose in white bread intravenously. And that may be an issue also with the bumps in glucose after exercise. It's the equivalent of intravenous glucose, so much less of a bump in insulin than when you're going through the small intestine. And if you're dumping your food into the distal small intestine, you get the benefit of the GLP-1, agonist, GLP-1 hormone, which now there are all the GLP-1 agonists that work extremely well for weight loss and reversing diabetes. So that's another advantage. And in fact, fatty liver regresses really in no time. And triglycerides, all the changes happen really, really fast. And a lot of it's because you're bypassing the GIP and you're stimulating the GLP-1, which has become one of the most successful diabetic medications.
Yeah, and I'll just add my 2 cents just regarding weight loss surgery in general. There can be a bit of a bias against it, even in the low-carb community, and I just want to say I know people who have gotten gastric bypass and things like that while keto, even after years of keto, and they found it to be a useful tool. Obviously, in an ideal world, no one would need surgery, but we just don't live there. So I just wanted to throw that out there as well.
And 2 more little practical tips that you can actually take home and use. One, you probably won't be able to eat OMAD 1 meal a day, especially with the Roux-en-Y, but you can still practice time-restricted feeding by having 2, 3, even 4 small meals in a time-restricted feasting window. And then secondly, speaking to what the good doctor was talking about with you've lost basically all of your absorptive surface area. You can't absorb the vitamins and minerals like you once did because you basically got hit in the guts with a truck and knocked some of your guts out permanently. That's effectively what this is now. Dr. Sivas would describe it much more eloquently than that. But basically it's a trauma to your gut that takes out a lot of your absorptive capacity. And so in that landscape, then what I don't want you to do is just take a vitamin and mineral supplement, some of which are very poorly absorbed, even by those of us with an intact gut. And so remember, try to get those vitamins and minerals from real food if you can. If you don't currently like liver, learn to like liver, okay? Because 2 or 3 ounces of liver is like taking a multivitamin, the vitamins and minerals in which you can actually absorb. So some practical thoughts.
I'm going to add a counterpoint. I would suggest if you don't like liver, find other sources that are rich in nutrients that you do like. I actually get physically ill from eating liver, and that's not being a baby. I will eat lamb brain. Some people have issues with certain things. Find something else that gets you the same benefit and that you actually like eating. That's my thought.
Get it from food if you can.
Ready?
Yes.
Yeah.
I'm going to ask you guys a question that is asked of me fairly often because I'm in several different electronic forums and whatnot. And this has to do specifically with people that are in this lifestyle because of, compelling physical reasons. And the question is, if I get my diabetes reversed, it's years down the road, my numbers are stable. And I'm not talking about people that are addicted to carbohydrates. I understand the difference. So we're talking about somebody who's reversing diabetes. We get down the road a few years, and the question is, can I add back some, I don't want to use this word, real food carbohydrates there? I'd just like to hear your guys' general opinion about that.
So I can add my thoughts. I think it's really just up to personal preference and also where you are at health-wise. I know people in different camps, like I use keto for depression management and lipedema management. So for me, it's probably just never going to happen. And I don't really want to anyway. But I do know people who've added back like more paleo type, although that's probably not an apt description, like potatoes and sweet potatoes, and they were able to tolerate it. So probably if you were going to do that, you'd probably just want to start out slow and then see where your tolerance level is, and then just do what you enjoy and what you feel works best for you.
Yeah, for the patients I work with, it always comes back to what are your goals? Why do you want to reintroduce these things? And, if it's going to benefit you, great. If it's not going to harm you, okay. But, in the end, you got to be paying attention to, remember what your health problems were that got you started. Be clear about what your health goals are. And whatever food it is, if it's supporting your health goals, then great. And if it's not going to support your health goals, then not so great. So I think you have to always be keeping in mind, what's the reason, what's the motivation, what are you looking for from either reintroducing foods or taking away foods, as you're going in both directions on this journey.
I don't know how many of you can remember Dr. Atkins, but kind of in this vein, he said, you would cut down to 20 grams of carb, you would check your ketones, and then every week or two you would add 5 grams a day and things. So it depends on how you're measuring your success and how you're measuring your goals. And sure, I guess you can introduce that. And some people don't want to, but other people do. So, it's common sense. Just see what works for you. And if you're getting out of what your range or objective idea is, then you have to cut back. I think this is a dynamic, lifelong process. So the more cognizant you are of what's going on with your body and the results that you want and your doctor wants, I think just use common sense and fiddle with it.
Yeah, and just one other simple thought. I mean, we don't want to create a world of orthorexic people. You know, we want people to have good relationships with food and enjoy life and remain healthy. So it's very individual when you see people where they're at, what their goals are. But you want people at the end of the day to have a good relationship with food, because then they're mentally and physically well. We see a lot of people counting, measuring, and they're not well. I mean, it's not a good way to live for the next 50 years of your life. You want it to become automatic, and then trusting how you feel every day. You know, I'm an exerciser. Some people like to have a little more carb when they exercise. Some feel much better with zero. And so, like, how you feel mentally and physically, I think, forget about blood test stuff. That tells you a lot of shit's working well, right? If you're sleeping well, you've got mental clarity, and if you're doing Ben's workout and you crushed it, that's a good day.
Another approach that you can use if you want to just have more variety in your diet that works for some people. Back in the late 90s, I was doing a low-carb diet, and I had a rule for myself where every Friday night I could eat whatever I wanted, and I would go to the pub and I would drink beer and I would have fries and whatever it was that I particularly wanted. And for me at that time, that worked perfectly well. The next morning I would work out and be right back on my diet. And so an approach like that can allow you to get some pleasure in and some variety without totally compromising all of your goals.
I agree with everything that's been said, and everybody is individual. And yes, I talked about the different causes of hunger. You know, if you're a sugar and carb addict like me or Rob, you know, that's why I narrow my feeding windows. So whatever I eat during the day, I know that's not going away. If I eat pie, I'm going to want more of it. But the other is cravings. And if you're having cravings come back, that means your insulin levels are sustained high and you're insulin resistant with beta cell dysfunction. You can measure that, but if you have cravings that have come back, it means you're there, and you have to go a little bit in the other direction.
I'll actually add to that. I've found that when I do experiments with calorie restriction, I can actually get carb cravings too. So I suspect that one of the other factors that may play in with cravings is just an energy hunger, in which case eat more and eat more energy specifically, and that sometimes helps if you don't want to have whatever you're craving.
I'm going to be a little woo-woo for a second and just say, like, the speeches that you have given and the talks you've given this weekend have been kind of the culmination of your life's work, and we're so grateful to have that. And I kind of just look at the stage and the other people that spoke and think about all the lives that were saved by the messages that you share and the work that you've dedicated your lives to, and I know we're also grateful, and the people in this room also are a part of that. If you could, have the world wake up tomorrow with a couple sentences of something that they would believe to be true or know to be true, like, what is it that's your mission that you just wish we could download into everybody's brains tomorrow, and that they wake up knowing, and we all move forward in this way? So, like, what is that in a couple sentences?
Meat and eggs are good for children. Meat and eggs are good for human beings of all ages, from 1 minute old, which would be breast milk, but then when a child starts to wean and have teeth, meat can absolutely be their first food. Scrambled eggs can be their first food, and in fact should be their first food. I just had a lady send me a picture of the handout her pediatrician gave her, and it said, avoid meat and eggs in the first year. Literally said that. Rice cereal was the top recommendation, and fruits and vegetables and berries. Avoid meat and eggs for the first year of life. That was the literal black and white recommendation from a probably board certified pediatrician. That's it. And then number 2, fruit juice is Satan. It is just as bad as Coca-Cola for children and adults.
Yeah.
That if I could just imprint that in every brain, Homo sapien brain on the planet, I would retire and just take my chainsaw and go to the woods.
You know, I'm not a very good business person because I'm trying to put myself out of business as a heart surgeon, and I'm also going to, ruin the sales of my books by just summarizing it as eat real food. That's it.
I have two to offer. One of them is if you're looking at a condition and your urge is that it's genetic, predominantly genetic. If you look at indigenous or otherwise healthier populations and there's a lower rate of it, it's not 100% genetic. Yes. The other one is just in general, just keep trying. My process over the past 5 years has been trying different things, tweaking. I've done a bajillion different experiments even before I met Dave. And it's just a process of trying to see what works best for you. If you're still struggling, just keep trying. Just keep trying.
Well, as not being known that much for carnivore, my first advice would be as an elimination diet, eat steak and eggs. And that's about it. And then you add something back depending how you respond. But I think that's a true elimination diet that everybody should start on if they've gained weight. The other is to get out there that how early the process starts. And if you as an adult have gained any weight in your belly, you have fatty liver and a fatty pancreas already. And if your parents gained belly weight as they aged, you do have a genetic predilection for this. And so, patients who say, when I say they're pre-diabetic or pre-diabetic, and they say, "Oh, tell me when I'm diabetic," I said, that's way too late.
What you believe has a huge effect on the things that you perceive and see and the solutions that you'll be open to that could pass right by you if you didn't have the right belief. So I would say don't feel committed, be promiscuous, try on a belief and see what happens if you believe it. Even if you don't really believe it. What would it be like if I believed this? The crazier it sounds, maybe the more you could try out. What does it feel like? What would I know if this is what I believed? And then you could find out what happens, and maybe you'll say, well, yeah, I was right. That was a crazy idea. But maybe you'll actually learn something to try to stay open.
Just have two quick ones. One would be just hard lockdown on sugar. I think we all know what that means, hard lockdown now. And the other is just play. I think we've eliminated play from lives, and play is no outcome, whatever that is you like to do. But if we extract that from kids' lives, then they won't even know what it is as an adult. But all of us need to have outdoor play. And so get that back in your life if you don't have it.
I think the first thing I would like to tell people is to understand their value, to basically just take care of themselves because they're worth it. Okay, your body, you get one body, you get one lifetime, unless you're Shirley MacLaine, and you can basically, I think, take care of yourself, try to educate yourself, don't ever close your mind. I hope I never close my mind to new things that work for people or for myself. So just take care of yourself, just be sensible about the whole thing.
Thank you all very much.
Sure.
My question is on coronary calcium scores. So I just started ordering more for my patients. Actually, I just started ordering them, which has been a little bit of source of contention in my practice. But so I've listened to Ivor Cummins, and he describes if there's less than or equal to 12 to 15% progression per year, then that's a stable progression. And does that have to do with the density of the calcium? So you may have a higher score, but also a higher density per deposit, per calcium deposit? Is that what he's referring to in that 12 to 15%?
I was a good friend, and he has that right. The calcium it's an area of healing, and the problem starts with the degeneration of what I call a cholesterol pimple. It's a soft plaque that never becomes obstructive, and you don't usually say never in medicine, but the vessel remodels when you have soft cholesterol plaques. When it ruptures, you end up with a little clot and an area that scars, and it's becomes stable scar in a few weeks. Calcium starts to form in it in 6 months to 2 years, and then the calcium continues to form in the area of the scar. So a large calcification means it's been calcifying the scar for many, many years, and we can pretty much tell this is 20 years old, 10 years old, 5 years old. The less dense and the smaller the calcification, the younger the lesion is, and the more you have to worry about active disease. So from continuous calcification of scar tissue, your score will go up about 10 to up to 20% per year. And I hate to say the score is not good for something, but it's horrible for following people from year to year. If you follow a population that's treated appropriately and aggressively, you will, over many years, it's easy to see you'll have less progression. The reason is because you won't be forming more of those cholesterol pimples that pop and become calcification. And so, and what we do in our practice is we look side by side, and what we don't want to see is new young lesions popping up. The old ones will, and this is seen directly as well as the literature, will get more dense and larger, but they're only in that area that was scarred at the time that you first ruptured the plaque. Your chance and your risk go up with higher scores. Well, one thing, it all starts proximal in the large vessels, particularly in the LAD. So people used to run and say, oh my God, I have something high up in my widowmaker, better get cath. That's already inert lesions. Doesn't matter where it is. But as you get more plaque and you get a lumpy, bumpy, stiff vessel, the flow becomes irregular. So if you see, took a great picture of the Colorado River from a plane, and when the water goes around the bend, the silt builds up on the inside where the water flow is slower. Same thing with arteries in general and coronary arteries. It builds up when the blood is going around a curve, but once you get lumpy and bumpy, you get a lot of irregular flow, where just like you dump silt in the Colorado River at a bend. And by the way, the other side where the flow is going faster, you see a little canyon, because the flow is going faster on the outside than on the inside to end up in the same place. And so as you get a lumpy, bumpy vessel, you get non-laminar irregular flow, which lays down more plaque, particularly more cholesterol plaques, and it also makes the platelets more sticky, more thrombogenic. So that's why it's usually not till scores of over 400 that you really start to get a lot of events. And so that's the way the physiology is. And the only unfortunate thing is that from one year to the next, especially if a little plaque, and it's just seen at different angles, the score can go up a lot. When we developed the score, it was over lunch when we were just figuring out some way to quantify for the first paper. Didn't know it was going to stand the test of time, which it does because it's a good summary of the total plaque burden. But from year to year, it's not a good way to follow individuals. So you have to sort of find somebody, particularly early on, when you can count the plaques and see them, they are very easy to follow, which is why it's good to start people with bad family histories and bad metabolism at an early age, because you can see if new plaques are forming very easily. Once you get a very high score, it becomes technically much more challenging. But sorry, but you can't go by the score alone.
Okay, so you're saying go by the score, but also look at because our reports don't report densities. They report the total score, and then they show the map of the 4 vessels, and we'll plot them on the vessels. So important to look at the new
makes it very difficult to really know. As far as semi-quantification, for the initial risk stratification, the total score is very, very helpful, and that's really the ballpark. The problem is if you're repeating the study, then overall, Ivor is right that 10 to even 20% is usually stable, but everybody's different. So that will be, if you're doing a big study, that will tell you what's happening in a population, but there's too much error in the way it's done to do it in an individual. So what we do is we actually repeat it. The radiation in the new equipment is absolutely minimal. Different than radiation used to be in CT scanners, and the cost is way, way down. So we follow patients looking for new, it's not everybody, looking for new plaques that are young, meaning you haven't controlled the situation. And we do it actually every year, because for technical reasons you can miss a plaque 1 year, but when you have several years, it becomes very easy to follow up. But the problem we have, somebody comes back in 1 year, what happened? Oh, my calcium score that they see went up, I'm gonna die. And that's part of my life, explaining to those people, no, you're not. The problem is not enough, you have to find radiologists who have experience at looking at a lot of scans, who can compare directly 1 year to the next and saying, is it progressing with new lesions, not with scores or old lesions becoming larger?
So you're looking at maybe in every 3 to 5 years in somebody who's, everybody's metabolically unwell if they have coronary calcium.
No, I've been trying to get people interested in doing a new score, which particularly, and we've followed people now for 20, 30 years literally, and when you have control of the situation, the old plaques become bigger and you don't see new plaques. But we want to actually quantify with a histogram showing the old versus the new. And the old, if you just have calcifications with a high score, they're all old, no problem. But if you see a bunch with a low score, then you're still progressing, and you have to figure out a way to treat more aggressively.
Okay, great, thank you.
Okay, Arthur's not allowed to answer any more questions for a while.
I have a few more slides.
Put them up.
We'll give you the clicker.
So my name is Ada Ramos. I am a nutritionist, and Dr. Pate kind of stole my question, so I have to come up with a new one real quick. So your definition of metabolic flexibility, because in my eyes, that's what we all should aim for, being able to tolerate carbs and burn fat efficiently, maintain weight, and good metabolic health. But I find a lot of people in the keto community, when they get stuck or they don't feel, like they're progressing, they keto harder, they go carnivore, they do more fasting. And sometimes I feel like perhaps doing a little bit of a break and introducing carbs can be beneficial. So I want to get your thoughts on those points.
I think it really depends on the person and where they are in their health. For me, I've done the carb thing after keto and it didn't end well. because of my lipedema probably. And also it depends on what they're dealing with as well. So like I've said, I deal with depression and I manage that with keto. So for me, going off of keto is like going off of depression medication, which is unpleasant. But in someone who can tolerate it, I think tweaking like that and seeing if maybe introducing some carbs and then coming back off or whatever may help. I mean, it's just in the tool set of things you can try. So it just depends on the person, I think.
Metabolic flexibility is the ability to use different fuels appropriately, right? And so a lot of people who are here because they have glucose intolerance. And so if the issue really is that you have glucose intolerance, then just because you're having some kind of stall or you're not meeting all your goals doesn't mean that going back to glucose is going to in any way help you with that. If you are already metabolically flexible, then going back to carbs sometimes maybe could have benefit. But there are many reasons that you could be stalled on weight loss, and I don't think that if you have glucose intolerance, that going back to glucose has any promise or benefit there.
Yeah, there's a good book, Bob Seebahar, he's an exercise guy out of Colorado, has a book called Metabolic Flexibility. It's basically being a normal human. You know, so if you're well, like think of an Amish kid on the farm, right? They can come back for a farm breakfast, maybe even have a biscuit, and they're not snacking all day, have dinner, go to bed, wake up, do like 3 hours of chores, you know, and they're fine, and then they come back for breakfast. So they're burning fat at night. You know, it's like a good hybrid car, right? Your big electric battery is your fat engine. That's called your aerobic capacity. And whether you're an athlete or a farmer, that needs to be built over a lifetime. And then, you know, yeah, you got to light matches to do some workouts with Ben. It's nice to be able to burn a little glucose and glycogen if you're doing some HIIT stuff. But your cruising should be, that's the RER, your cruising should be fat burning for just a normal human. But as Amber's saying, if you're not a normal, healthy human, that's our dietary guideline issue, because the majority of our country now are not that normal, healthy person, and they've got to reduce their insulin resistance, and then they can become a normal human again. But that could take several years, and for some, maybe never. Like they're never going to be able to tolerate the carbohydrates. Anyone else have any thoughts? That's a good, you know, Bob Seebahar. Listen to him on some podcasts.
Yeah,
So he's really shifted
again,
to low carb, and for his athletes too.
What was that name again, please?
Bob Seebahar.
Thank you. Thank you, guys.
I think the term metabolic flexibility is thrown around very loosely, and a lot of gurus and influencers will throw this up as some sort of mythical goal. I don't know of anybody who's been keto for 5, 10, 20, 30, 50 years who cannot immediately utilize glucose if they eat glucose. I don't think your body ever becomes inflexible because of eating a proper human diet to the point where your pancreas goes, what the hell is this glucose? I don't know what to do with that. And I don't think that ever happens. And I think if we would rather think with a new paradigm and say, you know, for many of us, too many carbohydrates is a toxicity. And so, you know, it'd be like, well, I really want to develop metabolic flexibility with respect to antifreeze. I want to be able to drink some antifreeze and not have any untoward effects. Well, okay, but if we've already figured out that antifreeze is a toxin for you, then why would you ever want to develop the metabolic flexibility to be able to drink a cup of, just an occasional cup of antifreeze on my anniversary? Yeah, so for the vast majority of us, carbohydrates are it's a toxicity, and we do best when we avoid that. So I have no desire to develop any metabolic flexibility so that I can eat honey buns again and, you know, somehow benefit physiologically from that.
Yeah, I was interested to hear Ken's response, because if you think about it, I don't quite understand. I was talking to some nutritionists a while ago about this. I said, I'm not even aware about what that means and what the advantage is, honestly. And I agree with Ken. I mean, I've been doing keto personally for 50 some odd years, and I can metabolize carbohydrates anytime I guess I want. But so I think that there's the definition of that. I'm not so sure I know what the definition of metabolic adaptability is. I mean, I don't get it. I don't understand what that means, honestly.
One comment on the why would you want to have something toxic? Do you drink alcohol? or caffeine, for that matter?
Full knowledge that it is toxic.
Another thing with weight loss stalls, though, is there are a lot of components that can go into it, and I don't think we even fully understand all of them. I know people who've stalled out and they kept doing the same thing and just waited, and it resolved on its own. It could be repair going on, it could be recomposition, all that type of stuff. But then also sometimes people need something really specific, and you just kind of have to tinker and try and figure it out. I mean, I have personally experienced, and I'm working with a couple other people who have found that high-fat carnivore in particular has been really helpful for things like persistent diabetes, even on a ketogenic diet, or even weight loss stalls that persisted for 2 years on a ketogenic diet. So I think as a community, it's really our goal to kind of understand what's going on and then kind of shuffle people towards whatever they're likely to work best with. I think that's my goal, at least.
I'm going to just push back a little bit because, glucose is something that our bodies should know how to use, and it's something that our bodies make, and it's something that we share with organisms across all of the animal kingdom to be able to use glucose. And I would really like to see my body be able to use glucose more. I think it's a marker of ill health that I can't do that, just like I think it's a marker of ill health that I have such low plant tolerance. And so even though I don't ever see myself being a high starch eater or a high glucose eater, I still think that it's a nice goal to be able to have that flexibility.
Do you still do Friday nights?
I don't.
So 2 points. One is just to keep in mind that ketosis and glucose burning are not mutually exclusive. They're both always going on to some degree in all of us. This whole thing about metabolic flexibility, though, I think goes back to the default assumption that the standard American diet, is the default diet, and then if you're doing something different, such as keto for a time, that you then have to somehow get back to being able to tolerate the standard American diet. And we really need to change that narrative that the standard American diet is metabolically inflexible. If you are only burning sugar all the time and you can never get into ketosis, that is metabolically inflexible.
If Doug lets me, just a quick comment. It's my feeling about the flexibility was I thought that meant you were fat adapted, which can take quite a bit of time, and that you essentially, if you run a marathon or do an endurance run, you don't hit what was called hitting the wall, and the reason why everybody carb loaded, because when you got rid of your carbs, you weren't used to burning fat. And when you're keto low carb, for a while, you learn how to burn fat, and your endurance is much, much, much better. You may need some carbs for some sprints, but that's what I thought metabolic flexibility was.
Yeah, and I'll just go ahead and agree with Amber that even if I don't intend to eat carbs again, I think it would be a good sign if I were capable of that, because like she said, I do consider glucose intolerance under the conditions of pathological insulin resistance not a great sign in terms of health. I mean, you'll see it in infection and very severe trauma and other assaults like that. So if you have that going on, it suggests to me that you have some sort of chronic immune activation going on, whether that's from injury or something else. So I just agree with her.
The Bible of what the good Dr. Agatston mentioned, which is the fat adaptation, is Phineas Volek, The Art and Science of Low Carbohydrate Performance. It's a little paperback, but it'll explain the whole thing about how long that process takes to basically up your level close to your VO2 max and still be able to burn fat. And that's a good place to be because you won't bonk or hit the wall, whatever they call it. You can just make energy all day. But then you do get a little hungry sometimes, and you just eat a little real food if you do these crazy long endurance runs or hikes. But that's a really good read. And it was published about 10 years ago, but it's still, everything in there is like spot on.
One other point about, we're talking about carbs and all carbs are poison. Steel cut oatmeal versus instant oatmeal. David Ludwig did some very good studies. And it's not, fiber does not save you, but when you have fiber around the starch core of steel cut oatmeal, and you eat that for a few meals, versus instant rolled oatmeal. Rolled oats meaning you've broken up the fiber, you have the same amount of fiber there. The real whole oats are digested gradually, so you don't get all the GIP incretin, you get the GLP-1. But if you have the instant oatmeal, then you're pouring out the GIP-1, and that will almost always be toxic and make you sick. But other carbs are much healthier.
Yeah, I'll add on to that I personally don't believe the all carbs are toxic thing either, just because we have evidence to the contrary. There are many, many, many indigenous populations and other populations eating traditional diets who were able to eat high carb and they were okay. And I think that's really important to acknowledge, even if we are low carb and find that helpful as a therapeutic or even just baseline diet. I mean, even if you look at Okinawa, they ate a lot of pork, but they also ate sweet potato, and it was only when Western diets were introduced that they started getting fat and sick. So Western diets are not all high-carb diets, and I think it's important to differentiate those because I think it can also confuse the source of the issues that we're seeing, which makes it harder to figure out what the actual problem is.
Okay, I just wanted to make a statement that every time I come to a conference, I learn something more. And then I say, there's more I don't know. But my first course book that I got after college was South Beach Diet. And then I've gotten the most recent one, which was Stay Off My Table. I learned so much from you guys, and thank you for that. When I was listening to Siobhan's talk earlier today, it made me think about Dr. Ben, and I asked her, but it's something I want to ask out loud, is the role that the slow resistance exercise may help with some of the fat burning and lipedema, maybe even pain, swelling, inflammation, what his thoughts might be if he's seen truly 1 in 9 women have it. Has he seen that, experienced it in his 50 years of treating from kids to old people with his exercise program, how it might help lipedema?
To be honest, I haven't seen it certainly not 1 in 9, okay? And lipedema is kind of almost a newer categorization. But as far as pain, if we're talking about exercise causing pain, is that what you're talking about? Irritation, inflammation, something?
Siobhan was talking about the painful connective tissue.
Okay.
So like the lymphatic, the extra swelling, inflammation in those areas.
Okay, yeah.
That if your exercise, would that help push through or?
Well, as far as Johns Hopkins School of Medicine called me about 15 years ago and asked me to set up a program for JIA kids on juvenile idiopathic arthritis. And those kids, it hurts those kids to move, okay? But they took to the slow training because mechanically it wasn't that disturbing. And we measured different cytokines and things like that. And interleukin 6, which is normally in a triad of an inflammatory triad, when generated at the site of the muscles, is actually anti-inflammatory. Okay, so muscle-generated IL-6. So it increased IL-6 in the kids, the kids actually, and here's the problem with this juvenile condition. At 12 years old, they're sarcopenic, osteopenic, they're diabetic because they don't move. Okay, and we can reverse that. So I mean, it's kind of serious, but the kids didn't have a problem with the slow movement. Again, we reduced the mechanical forces, which were painful. We induced muscle growth, protein uptake, and the signaling of an anti-inflammatory signaling that reduced their pain. So the kids moved better, and it was a very successful study. I see this all the time. I mean, you produce a local inflammation in the muscles when we exercise them to a certain level, and what does the global response is anti-inflammatory. I mean, that's a healthy response. So as far as pain reduction, all of us up here know that if you tell a rheumatoid patient or an arthritic patient to move, they feel better. And there's some psychological behavioral aspect to that, I guess, but there are real chemical, hormonal responses, and the myokines can produce a significant anti-inflammatory, pain-reducing effect. I don't know if I'm answering your question, but it definitely, yeah. So if you're going to apply exercise to produce an anti-inflammatory response, you would want to be certainly cautious of the mechanical imposition of violent, vigorous, fast, jerky movements. I mean, that's simple.
Yeah, and I'll add on, I don't know about the fat burning aspect because with lipedema there is scar tissue within the fat which may impede that. And I definitely suspect that after the fasting experiment, given just how I felt despite how much fat I had left on me. But activity in general, yes, for sure. It's encouraged with lipedema generally, and I think the low impact, slow movement type could be particularly helpful, especially because like I've always experienced, I hated running because it hurt, and it didn't necessarily hurt my muscles, it hurt the fat in my legs, and I didn't realize that's what the issue was. I just knew I hated it. But I have tried like isometric exercises and stuff like that where it's much slower and not as much time also, and I did find that much more tolerable. So there's that, and yeah, after I'm done with my current lipedema experimenting, I'm gonna try his stuff because it seems fun and I have the extra energy at this point.
One other, I met Dr. Ben just a few years ago, and it was still, always the debate of aerobic versus resistance. And I've always done a lot of sports, but I hated resistance exercise with a trainer in particular, one more rep. I said, well, 15 minutes, that I always thought it was important. That may work. So I tried it on myself and then started just sending some of Ben's lectures to patients. And we do our craft test, we do our Fit 3D where we measure lean body mass as well as fat mass, and it's really quite reproducible in individuals. And we've seen so much direct improvement in what we're trying to do, improve insulin sensitivity and decrease fat. And we see fat go down, lean body mass go up, A1C go down, and dramatic improvements in the craft testing. So, whatever resistance I had to resistance exercise, 15 minutes twice a week, I can do.
Also add another potentially important aspect is that with lipedema, you can actually see low muscle mass in lipedemic areas specifically. So I'd be really curious if resistance training of this type might actually help with that. My muscle mass appears to be fine in all areas, luckily. I don't know how much of that was present compared to now. But I'll be interested to see if it goes up, or in other lipedemic women if they want to try it, if they find it helps, because muscle's kind of important.
I actually, at the risk of the wrath of Doug, I'm just going to tack on one tiny comment before my question, which is I do have a 101 version comment of metabolic flexibility that I give to my friends and family, which is super simple, which is whatever diet you're currently on, you're good at putting fuel into storage and also getting it back out of storage. Pretty straightforward. I think it's a spectrum. I think that nobody is truly metabolically flexible because there's going to be some diets that aren't going to work for you. So here's my question.
Wait, can I comment?
Go ahead.
Can I comment on your comment?
Go ahead.
I would add good at putting energy into storage, taking it out, and utilizing it. I think that's an important component.
Fair enough. So my fun question for the panel, it's 2022. Where do you think keto in the community will be 3 years from now, 2025?
I think it'll keep growing. I mean, don't forget, I put people on ketogenic diets starting in around 1975. And when my first people went to the pharmacy to get keto sticks, the pharmacist called me and said, what's going on? Are these people all diabetic? And so it's definitely grown. And I see, in this community, for example, I see this thing really taking hold because you got smart people up here, you got good people up here. The science is more significant. I think it's going to grow because as Ken says, it's the healthy, basic human diet, and I think as we revert back to that, we're going to get good results. And I think more and more people are cognizant of the fact that we're screwed pretty much metabolically. We can't even afford this fiscally to keep this up, and certainly personally, and for the people that we love, this is bullshit. I mean, we have to turn it around. Okay.
Yeah, Tom Naughton, who wrote the book Fathead Kids, he gave a talk called The Wisdom of the Crowds versus the Power of the Anointed. So we're only seeing, it's the wisdom of the crowds is really what changes the world, but it's slow change. So that will not go away. And ultimately, just like you saw, West Virginia University just contracted with Virta. So like you're going to see the top down ultimately get it, but the wisdom of the crowds will keep growing and growing and growing because you can't unsee this. That's why you all are here, even during COVID. So share it with all of your family and help them, lead them to good quality resources so they do it right. Buy all the books of everyone up here. Right? It's simple stuff. It's not rocket science. They don't need to know biochemistry. It's fine.
That's a really tough question, Dave. When I found a low-carb diet, I guess in maybe what you'd call the second wave, because it was in the late 90s and there was kind of a revival, and people were calling, a lot of people were still calling it Atkins at that time. And when I started diving into the science, I thought, oh my God, people are going to read these papers and see what's happening, and like within 5 years, this is going to be the standard of care. And I really thought that. And then not only did that not happen at all, but the popularity waned again. And then I think it surged again with Gary Taubes's book, which was in the early 2000s, and then maybe went a little bit cold again. And now, but I feel like every surge is a little bit bigger. So I don't know if, when are we going to get to the point where it doesn't actually fall and just keeps going up? We might be on that one, but I have to admit to being a little more cynical than I was before.
One anecdote that makes me optimistic, at least in the end, was way back in the early days of statins. And also when I was just getting interested in nutrition, and at the American Heart Association, I went to a nutrition session where the RD was telling us how to measure calories. There was actually almost nobody there except for me. There was just zero interest. And then I moderated with one of the new statins, a group with a lot of local doctors and cardiologists, and they gave us case reports, and the standard was then, you're supposed to, with somebody high cholesterol, supposed to try diet first, and then if it doesn't work, and the statin companies had to say that also. So I'm reading this first case report and saying, as a group, what would you do? And they said, well, what would you do? So I lied and said I would try diet, and they started like screaming at me in revolt. So all these people weren't going to meetings on low fat, measuring calories, and they didn't believe it, which is why they all started using statins, because there wasn't low carb there. And once people have experience, and like most of this group and the doctors who get into it, they have an experience with themselves or with a few patients that did great. And I don't believe anybody has those experiences with vegans and vegetarians, despite, I mean, they're rare cases, usually people who are healthy in the first place, and when they go vegan, they go off sugar and processed food also, where they can improve. But I'm optimistic that the truth will prevail in future years.
So you know I'm the pessimist of the two of us. But coming to these conferences and seeing the work that Verda and the fasting method and all the people who are not just talking a product but also pushing for the advancement of good science makes me a little optimistic. As far as where we'll be at, I hope we'll be further than we are. I think we'll be further than we are, but to be honest, we want to believe that science is just science, but a lot of it is politics, and I don't know. I hope it continues, because I think this is helping a lot of people, and I don't think the end point is like ketogenic diets for everyone, but ketogenic diets for people who need them and want them, and just have them as an option. I think that's what everyone wants, pretty much.
Yeah, I would kind of agree with that I think, we're heading towards a point where we just have to have the resources available for the people who want this, who seek this out. I think 3 years from now is going to be 2025. I think Nina's going to be having the same fight with the U.S. Dietary Committee at that time. And I really don't expect at any time that the American Heart Association is going to come out and say, we were wrong about the low-fat diet, kind of ignore everything we said over the past 50, by that time we'll be 70 years almost. But what we have to do as a community is just, keep getting the word out there, keep connecting with each other, keep promoting, and just make sure that those resources are available for the people who want it, the people who need it, the people who are seeking it out.
I think over the next 5 years, Dave, we're going to see the term keto completely hijacked by big corporations, big food. That's going to happen 100%. That's kind of why Nisha
kind of
and
already happening now.
It's already happening,
degree,
definitely,
yeah.
but I think it's going to be just a complete hijacking. And at that point, if it says keto, you can definitely not eat that. I think within 5 years, that'll be saturated. Now it's pretty much true. If it says keto on the label, it's probably bullshit, right? And so I think you'll see that. That's why Nisha and I, on the low-carb cruise a couple of years ago, I was running my mouth, as I'm apt to do, and proper human diet just fell out of my mouth, and she was like, put a pin in that. That's good right there, because that's hard to argue with, right? Both from someone who's like, well, I don't have a gallbladder. Can I eat a proper human diet? Yes, right? But also it's going to be really hard once that term has been defined. It's such a positive term. It's keto is an absolutely valid term, but it sounds very faddish. It sounds very, sciencey. And so it scares a lot of people, namely dietitians mostly. But I think you're going to see that completely hijacked. And I actually asked Nurse Jackie, Dr. Atkins' nurse, for decades, I said, where's the tipping point? How close are we to the tipping point? And she says, I don't think we're there yet, but I think we're getting closer all the time. And I would echo my colleagues' thoughts here that this is never going to come from the top down. I applaud the work Mark's doing and Nina, but this is never going to come from the top down. Never is the ADA and the AHA going to hold a joint press conference and say, that low-fat diet thing? Shit, we were totally wrong about that. That's not right at all. Stop that. That's never going to happen. So this has to be a true grassroots movement where first you fix yourself, and then when you've made that transformation that's obvious to your friends and neighbors, they're like, what the hell happened to you? Then you teach that friend or family member or that neighbor. And that's how this is going to reach the tipping point ultimately, where it becomes accepted as self-evident that human beings are by design a low carbohydrate mammal, and we should eat nutrient-dense food every meal, and you can have a high-carb junk treat on your anniversary, birthday, and once or twice a year, that's fine, along with a tablespoon of honey. But other than that, you need to eat real, ancestrally appropriate nutrient-dense food on a daily basis if what your goal is optimal health.
I want to just tack one thing on there. I agree that those associations are never going to say we were wrong, but they might say we were saying that all along, and that's infuriating if it happens that way. But who cares, right? So one time I read this book on relationships in which the person was saying being right is the booby prize. So it really doesn't matter as long as everyone comes along to seeing things, whether or not they acknowledge that they were wrong along the way. Maybe that's less important. And I think one thing that might help us get us there is actually your work, Dave, because if heart disease is the last holdout, then maybe we can make some leeway there.
Thank you. Great answers.
Ken reminded me, he said, what the hell happened to you? So real quick, 90 seconds. Pirate walks into a bar, right? He's got a hook on his hand, patch on his eye, peg leg. Bartender said, man, what happened? He said, I had a rough couple of months. Had a fight. There was another ship. Cannonball hit me in the leg. I got a peg leg. I said, what happened to your hand? He said, sword fight. Guy knocked my hand off. He says, what about your eye? Was that from a battle? He goes, no, I was recovering on the ship, lying on my back, nice sunny day. Seagull came by and it pooped in my eye. He says, you lost your eye because of that? He says, no, not really, but that was the first day I had the hook. All right, sorry.
Okay, I've been asked to stand in the line here for the live stream folks. We normally say we have to get through everybody here first before they get a chance because you guys showed up here. But I think in this case we'll give them a chance for at least one question. One, you better choose a good one.
Well, I have a couple left over. I have 3 or 4 left over from Mark. Then they're kind of quick.
No.
He actually just said something about Verta coming to West Virginia. Did you have anything to do with that, Mark?
I helped at least present it and share some patient experiences, but yes.
Good, great. Okay, next question. Who provides the food service at your hospital? Is it a contracted food company or is the hospital doing it itself?
Sodexo is the company.
Sodexo.
Yeah, it's a big, they have the big trucks, right? They deliver the food, but then they prep it there in the hospital. COVID has changed a lot of stuff. Now a lot more is like prepackaged. COVID's been a disaster in so many ways for every forward movement of everything we've been doing.
Okay, Carlos Moreira has asked you that, MD. He says he's coming to start as an ortho in West Virginia next month, so hopefully you guys can connect. Can I just start one from Tro and it can kind of go to a couple people?
Okay, start one with Tro and then then you.
Okay. Can you talk about the emotional hardship of facing the vast machine that keeps the high carb train going? The culture that accepts sugar in the hospital, the culture that prevents the education of low carb approaches. How have you faced this all? He goes on to say, it feels like providers who want to practice this way are forced into private practice. Any comments for those in institutional academic practice versus the private practice contingent, like those at Verta who have been trailblazers? Mark, you can start.
Yeah, I think in that one little slide, I think you just have to have integrity. You can't, if you're a healthcare provider and you know something's going to help someone, you can't not share that with them. It's a human right. I bring it down to human rights issues that patients who have diabetes should be presented this as an option, right? Not that everyone's going to do this. I think even Laura and I were talking about this in front of patients. Right? This is a human right. If you have pre-diabetes, it's a human right to know what that is and know that's the slide, right? There's a fork in the road. It's a human right to know you can get healthy. And I think a lot of people, I don't think healthcare providers no one goes into medicine intending to do harm, and we learn things every day, right? That's why we practice. We're learning new things every day. But it brings me joy when the med students come through after a week. It's like they're young learners, and it's like a color they've never seen. To spend a day and like all these people coming off medications, then we can share the science, once they've seen it, because you can't unsee it when you see it. But just show up every day and give your best and just treat it as a human rights issue. And that's how I've defend myself when people attack you. But then you also have to go out and do the work, right? So if the people attacking you haven't published, I've been through the full promotion chain, I'm full professor, so you do all the work that adds credibility to what you're doing, and it makes it more difficult. That's why it's harder for younger people to defend themselves, because it's that power mismatch. If the person who's trying to remove what you're doing is like 3 ranks above you and has the authority to hire or fire you, then it's comfortable to stay with the herd. It's very comfortable just to do what everyone's doing, and you'll have a long career and never be removed from anything. But but that doesn't. Once you see that there's a better way, that's why we went into healthcare. So maybe that's my take and what keeps me going. But you do lose sleep over it, because you're trying to help your patients do your academic work, and then you're spending half your time dealing with other things that are just wastes of time. But yeah, it shouldn't happen. It shouldn't happen.
What you said earlier during your talk, Mark, about, and which you've reiterated now, that it's harder for junior people, really hit home for me, because as you know, I sort of semi-privately criticized someone for not being quite as forthcoming about their opinions as they might be, and they're in a junior position, and I probably should have been more sympathetic. But that means like the onus is all the more on someone like me who does not have any of those barriers. I'm not a doctor. Nothing in my professional life will ever depend on my opinion on this. So whenever you can stand up for a contrary belief that you feel authentically, you should do that. And as soon as you feel comfortable, help people and set a good example with that.
It's as far as that also the future of keto, to just reiterate what Mark's experience, mine also. When you're speaking to medical students, residents, cardiology fellows, they are much more open than the more seniors who don't really have time often to listen to anything new.
As I've mentioned, I'm not a doctor or in anything, but I sometimes struggle with this as well. It can be really disheartening being on Twitter and just interacting with the public and seeing my own family struggle with health issues that I know very well could be corrected possibly very easily. I come to these conferences. That's really my motivation point, and I'm really sorry you couldn't come, Tro. I was looking forward to seeing you. But, I rant to mostly Dave and Amber, honestly. I meet up with like-minded people locally as well, and just chit-chat and give hugs where I can, and know that there are other people trying to do the same thing that I am and are just as frustrated as I am, and that I'm not alone in that.
The quote that I had at the beginning of my talk about the biggest risk we take is really the risk of doing nothing, is one I come back to a lot. And it would be a lot easier for me to just continue I had a pretty comfortable life as a heart surgeon. But it's just, I think ultimately you have to do what is right. Those of us that, went into medicine, all did it because ultimately we want to help people, we want to help the patients, and we know this is right. We know this is helping people, and to not talk out about that, I think, is harder than, you know, whatever we have to do to be able to talk out about it. And again, just supporting each other as a community, I think, is the most important thing that we can be doing.
I think it's very admirable that Mark was able to get the dietary menu changed in his hospital. That's awesome, right? To get the Coke machines out, it's freaking awesome. But all of us need to remember that when you are an inpatient in hospital, you are not, well, at least not currently, you're not under arrest. You still have all your rights as an adult human, right? And so what happens if you tell them on intake that you're allergic to wheat, rice, oats, corn, soybean oil, and canola oil? What happens if you tell them that? What the hell are they going to feed you then?
Yeah.
Right? Okay, what happens if little Timmy on his first day of preschool, he's got his little information that mom filled out, and it says he's allergic to wheat, rice, oats, corn, soybean oil, and canola oil? What are they going to feed little Timmy? Right? So I think that definitely we want to be acting on an institutional level as much as we possibly can, but at no point do I have much faith that that's going to do much. I think that we're going to do this, you and I, these guys and you guys. That's who's going to do this, and sometimes it's going to require ninja strategy of being allergic to something. All right, and that, if that's what it takes, if we have to be less than honest in order to be able to eat the human food that we deserve, and that some would argue we have a right to, then I think that's not only ethical and honest, but also mandatory that you do that.
You see, Ken's from Kentucky and I'm from New York, so
Tennessee.
Well, okay.
I use a teeth brush, not a toothbrush.
Ken. See, I'm from New York, so I don't know the difference.
We all look the same to him.
Anyway, I think how I would say what Ken's saying is you got to learn how to play the game. Okay, don't let them snowball you. And stand for your rights, but you got to know the game. There's always a way to get around this stuff, and to have a better chance of getting what it is that you want to get by let them make the rules, and you figure out a way to get around them.
So I want to also thank all of you, the panel, and everybody who's participated. This has been a great 3 days. I've come to many of these, and I learned something new every single time. And I'm also very frustrated with not being able to help family and friends. They're just not learning ready sometimes, but it is up to us. I have a fairly specific question for Dr. Agatston and for anybody else who may have some information on this topic. When you state that you can look at a lean female who has a central pooch and says she has fatty liver disease, what about females who have been on hormones for a while, or postmenopausal women who have fibroids? And once those fibroids are removed, all of a sudden you don't have a central pooch. I know sometimes that can be caused by insulin resistance. I know PCOS has a connection there, but I'm not certain about uterine fibroids and whether they will also almost always say you have fatty liver disease.
I don't know the answer to that, but it's a simple solution. I mean, you can check your liver enzymes and your C-peptide and triglycerides and see what's going on metabolically. But anybody, there may be some other exceptions too, maybe some big ventral hernia or something, but in the great majority, early weight gain in the family is a good starting point.
Not a doctor. Again, I am a big fan of just looking at the big picture anyway, just for myself. So any time where I'm not sure what's going on, or I just want to check in on things, looking at fasting insulin and a lipid panel and all that type of stuff. And then also, you can check for fatty liver with an ultrasound as far as I'm aware, so that's not invasive at all. or DEXAs can calculate visceral fat, stuff like that. So in any case of ambiguity, you can look for other routes to kind of clarify the situation a little bit.
Yeah. I was just curious if there was a connection between fibroids and fatty liver, since there was that comment earlier.
There is a well-documented connection between fibroids and hyperinsulinemia
Oh, I didn't.
or
Okay.
insulin resistance. My YouTube video about fibroids, in the show notes, I've got, I don't remember exactly how many citations, but there's multiple research studies showing a very high association between women with fibroids and hyperinsulinemia.
Great. I was aware of the PCOS connection, but not the fibroid connection.
Endometriosis as well,
Great.
PCOS as well. One could argue that pretty much any of the ovarian or uterine conditions, perhaps even ovarian cancer and uterine cancer, are intimately linked with hyperinsulinemia.
Great. Thank you.
All right, great job. Always get great stuff here. My core thing is I believe with Dave that I'm not sure how much of this will get picked up and carried, but I agree, Dr. Berry, you've got the right approach. We've got to start pushing back. And if you do go to a restaurant and tell them you're allergic to stuff, they're a lot more compliant, and I've had the chefs come out, and I love your idea. Sorry, the question is real simple. With a future, I'm envisioning future med students graduating. They just graduated. They decided to watch this video. What would you say to a brand new graduated med student?
You were not taught anything useful about human nutrition in medical school. Everything you were taught about nutrition in medical school will harm your patients. And we have a couple of resident physicians. You guys are second year or third year? Third year. So last year of family medicine residency, is what I just said true? 100%, yeah. So basically you are a student by design, by nature, or you wouldn't have went to med school. You love to learn. So put your student hat back on. You can be an attending, that's fine, but you also need to have your student hat, and you need to go back to school and relearn human nutrition, because that, number one, that's the most powerful intervention, the most powerful side effect-free intervention that you can ever have with your patient, unless they've been in a trauma. If they fell off the roof, they need a level 1 trauma center. That would be the best intervention. But outside of trauma, diet is the number one no side effect intervention that you're going to actually transform your patient's life. That's what I would say.
For me, I would say, we all actually hear during medical school that half of what we learn in medical school is going to be proven wrong by the time we retire. And we need to remember that. One of our jobs as doctors is to figure out which half was wrong, and be continually reevaluating that. So, never stop learning, never accept the dogma, realize that you're going to be wrong about a lot of things, and that's okay.
So I would probably tell them to remember why you became a doctor. Most doctors that I know, and I really like doctors, I'll admit it, they say that they got to being a doctor because they wanted to help people, and I think that's important to remember. If what you were taught, if what you think is not helping people, and you can see that, just keep trying to find something that does. Try to connect with other people who are saying, I'm helping my patients, and try and learn what they're doing. And also, I know that can be very difficult, but I'll quote my own doctor in that you do have to care about your patients to be a good doctor, even if it hurts sometimes.
I just add that besides medical schools, schools of nutrition are in general so far behind the times, and we have several recently graduated nutritionists who knew it at the time, were often scared to speak up, and one of our internists who's outstanding decided to go back and get a master's in nutrition locally, and she was just amazed at the lack of knowledge of nutrition at the so-called School of Nutrition.
Medical training is really intense, and I think anyone who makes it through, well, there's a luck component to have had the life situation to be able to do that, but there's also incredible amount of stamina to to get through what they put you through. And so anyone who's made it that far, I want to thank them for persisting. But I also want to say, listen to your patients, because there's this temptation especially when you know a lot, to assume that if something's not working for someone you're trying to help, that they're not doing what you've asked them to do. And very often that it's just not the case. Things don't always work out. Even even here, even with low carb, people can be very compliant with low carb and carnivore, and they have some situation that you didn't take into account, and you look at them and you say, oh, I bet they're sneaking in carbs. Well, just don't do that. Listen, and try to have belief and faith in your patients.
I think it almost comes down to like what you do as a parent. You model for them. You create a safe food environment. So if I'm the attending, I'm not bringing donuts in, and then they learn. So most doctors are metabolically sick. I think everyone up on this panel probably learned this because we got sick in some way ourselves, and if you do that. I have a lot of patients who are doctors because they show you their labs. You start talking about this stuff, it's curious to them, and they see that you look okay at 55, so let me listen, right? You model that, and then they're all insulin resistant, and then they go do it themselves, and then they go teach others. So I think people have to heal themselves because they're all tired all the time, and they just think that's normal to wake up every day as a doc and just feel tired, burn out, hungry all the time, snacking all the time. But once they realize that there's a better way to live their lives, then they go back and read the books again. But I hope it doesn't. Doctors don't need to all get sick to learn this. But that's kind of where it's at now. I think the people really who are advocates for this now, have probably been on Phil's operating table. They're coming back after bypass, diagnosis of diabetes. They had a hard diagnosis, or a MACE, as Bill Cromwell would call it, and a major adverse cardiac event. Some kind of MACE, and then that's how people quit smoking, right? They get a diagnosis. And then they quit. They have a heart attack, or someone says there's a spot on your lung, and then they quit. So I hope it doesn't come to that.
I'm good. Just one of the comment, particularly for the low carb community, is credentialism, and that today, if you're in a big medical center, you want higher pay. You have to go to night school for some masters or whatever, which often is useless as opposed to doing a good job. And one of the things about this community, the idea that you have to be a doctor to contribute, is so the engineers here, the non-physicians. There's no physician who could have written books like Nina Tayschultz or Gary Taub, and it's very open, and it's certainly the only group that lectures meetings that I go to where you have this variety and where everybody accepts the contribution. You learn so much from non-physicians and people without all their credentials, but a lot of good experience, and do want to make that point. Doctors certainly don't know everything.
That's very true. Could I just add, any medical student or resident physician watching this now or in the future, everything that we're talking about, everything that's been in every one of our lectures, you actually were taught this in medical school. But for those of you who don't know, the first 2 years of med school are completely books. You just literally have your head in a book 24/7. Physiology, gross anatomy, biochemistry, cell and molecular biology, right? Third and fourth year, you go to the clinics, and you get to be a baby doctor and pretend to be a doctor. And then in residency, you actually get to be the doctor. So most med students hate the first 2 years. It's just nothing but books. It's just more. It's like the next level of college, more books. But if any medical student or resident or attending physician is watching this, everything that we talked about is actually in your physiology book from your first year of medical school. It's actually in your biochemistry book from your second year of medical school. And if you went to medical school late enough, modernly enough, it's in your cell and molecular biology book. You understand? When I was going back to basically medical school after I got fat and sick and was learning all this stuff, I'd be like, insulin, glucagon, ghrelin, leptin, I mean, they sound familiar, but I don't know a damn thing about them. And so I would finally got my old Guyton back out, and I'm like, holy shit, it's right there. In the first year of med school, it was in the textbook.
One correction, Ken. There are no textbooks anymore. It's all computer.
Graduated in 2000, so yeah, I'm an old guy. Yeah. But it's in your whatever resource you have. It's literally there in black and white the first 2 years.
Yeah, I will add that the best doctors that I've had, including my current one, the feature that I most appreciate is their persistent curiosity. I think that's a great asset, and also I'm quoting someone else from today who was talking to me, so I'll give them credit. But keep the curiosity and the caring, because it can make you a really fantastic doctor.
Yes. If you're not forever a student, then you're not a good doctor. 100%. Would you agree with that, doctor? If you're not still a student, you're not a good doctor. I think that's a hard and fast rule.
Sorry, but one other comment. With what's on YouTube and social media, you can hear the best people. You can choose the ones you like and don't. And I have a lot of very sophisticated patients, and usually they got something off YouTube, whatever. You'd think, well, who knows? They learn a lot. It's much easier than it ever was before, with all the great podcasts and lectures that we all have access to. That's the way I learn a lot. I see what I like, then I go to individual papers, but start going this directly from the horse's mouth, which is very, very easy to do today.
So I'm very thankful for that question, because my son just finished his first year of med school, and that's what I keep telling him, but I'm definitely going to send him this clip. So it's not just for me. So this is not a backstory. It's my question doesn't make sense without context. So I'm just, I swear to God, I swear it's not. So my question is, so that Doug believes I have one, is what baby steps do I give to my friends and family who want to start? But the context is, I'm just a fat guy that lost 200 pounds, got rid of 5 meds, and eventually, and so people, I'm not a health coach, I'm not a doctor, although I'm working towards being a med coach, a health coach. They ask me, what did you do? And when I tell them, their head explodes, because that's too much of a world change. So I fully believe in what Mark said, hard lockdown on sugar, and that includes carbs and different stuff. But then they go to Chick-fil-A and go, hey, I got the Chick-fil-A, I just ate the meat, but it's the fried one that literally has sugar in it. So it's like I can't really tell them that. I can tell them to eat meat and eggs, but they don't want to give up anything else. So what I've went to now, so you can critique it and then give me what yours is just eat real whole food. Go and pick up items out of the produce, from the dairy, from around the outside. Go home and process it yourself. Even if it's a cake, at least you have your daughter help you make it or something, so you get some family time, some play time, which, not that they should do that. So that's what I've been telling, just eat real whole food. I try not to go into, I do tell them try not, more vegetables that grow above ground than below ground. What's your opinion on that, or what would be your baby step? Because the people that I deal with, they're trying to feed a family. A box of mac and cheese is 50 cents. An apple is $2. They try to Mark Shatner's new book, The End of Craving. There's so much fillers and processed food that you get the calories but not the nutrients, and then your body's wanting to eat because of nutrients. So is there something better I can give them at that non-brain exploding, if you just start here, you'll see some progress, and then they'll come back and talk to me again?
So if they're just looking for low-carb information that's really easy to understand, dietdoctor.com. That's what I always send people to.
And I guess that's
but
more of
baby
they're
steps,
not going to do that.
Yeah, in terms of baby steps, it really depends on what their goals are. So one method that I've actually used on family members is Jen and David Unwin have a really good presentation, I think from Low Carb Denver, where they're talking about, I think it's called the GRIN method. It's essentially about talking to the person to establish what their goals are and then figure out tiny steps that they can take, which really depends on the person. So one person I had talked to was just switching out the sugar in their coffee for sweetener. For some people, it's just focusing on meat and veg with every meal. For some, it's just going to McDonald's and asking for no bun. It just depends on where they're at and what they would find easiest to start with.
I like your just eat real food. I think that's a great place to start. I think shop the outer aisle. That's great beginner advice. There are many ways now. My five are: number one, stop eating all sugars, stop drinking all sugars. Number two, stop eating all grains. Number three, stop eating all vegetable seed oils. Number four, if something has an ingredient list on the package, read the ingredient list, and if it has 1, 2, or 3 in it, then don't eat that or drink that. Next, stop drinking fruit juices entirely. Number five, eat more meat and eggs. Now, I actually just had this conversation with someone who's brand new to low-carb keto, and we could interview her and see what her recall was of that, if you'd like. She's sitting right here, and she doesn't look embarrassed. I think she'd be happy just to see what the uptake was, what retention percentage she's got just from our 10-minute conversation. Yeah, that's up to you, Doug. I know it's impromptu and it's not on the schedule.
That's
Here
actually,
she comes. It's too late.
No, I think it's a good thing.
Come on. Yeah. She's 50 years old. Sorry.
It's okay.
Okay.
No.
So you just an abject stranger says, how do I eat a keto diet? What do I do?
So I was telling him that I was kind of overwhelmed about some of the doctors because I'm just here because she's a keto coach. And I'm like, oh yeah, great. I've heard about keto and all this other stuff, and yeah. So first of all, before that, thank you about the fruit juice. So getting up at 2 o'clock in the morning when I have a sugar craving and drinking orange juice is no good. Right, so thank you. Yeah, so basically, meat and eggs. That's what I'm gonna do for right now. I'm not gonna worry. I work out too, so I was asking him, I was like, well, what about when I work out, and what about fruit and all of that? But I'm just gonna do meat and eggs 3 times a day, maybe going down to twice a day. And I've already written it in here. And salt, get my salt in.
That's not recall if you got to read it.
Oh, well, no, it's right here. Yes. And yeah, so, but my thing to your family is, just like they said, what is their why? And
I always ask them what their goals are, but I have to start somewhere.
Right. So the simplest thing, it really is that simple. I heard about the Carnivore Diet like 2 years ago, and I was like, that can't be healthy, like, because it was never really explained to me. But it is really that simple, just meat and eggs, and that's what I'm going to do. I took a picture with Dr. Berry, and I'm super excited to see what my results are going to be, and because I've been struggling. I used to be really physically fit, but I was always hungry. I was eating 5 times a day. And then after my 3rd child, every pregnancy I gained 80 pounds. With being pre-menopause, didn't know I was going through that, and hormones and stuff like that, I've just really struggled. My heaviest weight, I showed him a picture of my driver's license, because I won't change my picture until I hit my goal weight, but my biggest was 250. So, and then I've just been struggling, and I hear so many different things from paleo. Someone just gave me some advice the other day, not in here or anything like that, but, oh, you should have cottage cheese, and I was gonna try that, because I'm just gonna try anything, but cottage cheese, blueberries, raspberries, and chia seeds before I went to bed. And I was like, oh, so that will make me not wake up hungry. And so anyway, I'm super excited. Meat and eggs, bacon and eggs, bacon and eggs.
Perfect. Well done. Well done. Just 1 second. Sorry, so you're talking about trying to reach family, right? Or is it just? Or is it
Yeah, I'm
friends?
trying to reach family. I'm thinking about.
Okay, just quick, easy question. You're trying to reach family.
Yes. Friends.
Okay.
Friends and family.
Okay, so you might have some chance with the friends, but
No. Believe me, the family is the hardest.
yeah.
for
So
sure.
that I think that to get. I mean, I was all choked up on the stage in Seattle a few years ago, talking about how my family wouldn't listen to me, and that was the first time I got introduced to the phrase that Ken coined, that like parted butt syndrome, right? So if someone parted your butt when you were a baby, they ain't going to listen to you now. Right. Okay, so
There's a more polite way to say that a prophet has no honor in his own country.
Oh.
Yeah.
So.
Yeah, we have to realize that, we can't change everyone. This works for us. It works for a lot of people, but they have to want to be helped before you can help them. And, the doctors, see this all the time. I have the heart surgery patient who's going to continue to smoke or whatever it is. You can only help people who want to help themselves, and that's hard with family, especially. But once the best you can do is just keep modeling the good behavior, the good results, and that's what's ultimately going to speak best. But if someone doesn't want to be helped, you can't help them. If they do want to be helped, I think Eat Real Food is really the place to start.
I kind of clarified a little bit more for the insulin resistant, so I'll just make 2 sentences really simple in the clinic. Human diet is eat plants and animals, but if you're insulin resistant, they need to understand which plants are not sugary and starchy. And then we have the simple food lists, so they just need to know that a plant isn't a plant, right? So the banana and the potato are so much different than the Brussels sprouts. And once they understand that, and then they circle which non-starchy vegetables they love, and then they're off to the races. But there is a lot of confusion about like whole food or real food. I could eat 100% carbohydrates and it'd still be real food. So they just need to understand that they're insulin resistant, which I don't like that term. They're carbohydrate intolerant. That's what we use. We'll draw it out on a sheet of paper, on a napkin, that they can explain it, and then they get it. But eat plants and animals. But if you're insulin resistant, the plants, then you got to go into the weeds enough, because you set them up to fail. If they don't understand a banana's different than the spinach, they'll fail, and they'll be following your advice, and then they'll get frustrated. So they really need, and for Vinnie Tortorich, NSNG, no sugar, no grains, but they could still eat a lot of starchy. That's a nice, good place to start, but then they need to understand the plants, that there's a huge variance, and go from there.
Yeah, I was going to bring up something kind of similar about whole foods and real foods, because part of what people envision when you say that is very culturally or familially specific. So, my mother's homemade pasta feels like real whole food to them, whereas ground beef, that's not very whole, but it's perfectly fine. So. I had a child who had a lot of food intolerances, and I tried to explain to the parents, what they can have and what they can't have. And after much trial and error, the only thing that worked was, these are the foods he can have. That's all, nothing else. If it's not on that list, it's a no. And so for some people, I think just like a short list of allowed foods might be the easiest thing to do.
Okay, I think your question is like a little bit upstream from these answers, okay? You're saying, how do I get these people engaged, right? What do I say?
Well, just to clarify, I explain a lot of the stuff that Mark is talking about. I do try to talk to them, but their head explodes. Like, they can't take all that away.
Right.
I just need something for them to start with. Like, so what would you start with so they see a little bit of progress?
I would start with asking them, and this goes to what Phil was talking about, Do you feel as good as you want to feel? Do you look, as you're talking to young people, do you look as good as you want to look? Do you think you could look a little better? Okay, and let them bring it out. Well, Matt could probably lose a couple of pounds, or I'd like to be able to fit into this thing, or whatever. That's how I think you start. What motivates these people? In my opinion, in my history, pride, okay, and fear. Those are the big motivators, okay? And if you can tap into that a little bit, then you can start to tell them, you know, well, maybe you might want to look into this a little bit. This might help you a little. That's how simple I would start it.
Yeah, if they're the type that's ready to just jump right in and they don't want all the extra information, I've heard Eric Westman's page 4 is a really short list of things, and just say, eat whatever's on this list and hand it to them. That might be, if they're ready to make the change, that might be helpful.
That's great. Yeah, because the people I'm talking about, people have come to me, so I understand, Dr. Ovadia, what you're saying. If they don't want to help, they don't want to be helped. So these are people, you know, that are coming to me, asking, and they're wanting to change because I want to see that change, but then it seems overwhelming.
Download the little low carb on any budget book. It's like super easy starter guide, and the link to that's on the handout.
Okay, because we have to create a paradigm shift. And to do that, we need the little people.
Okay, we're going to take one more from the live stream group.
Thank you. Sorry, I wasn't realizing you were going to give me that chance. Okay, quickly. Glenn had some questions. And it could, he does, but I'm going to narrow it down. So, particularly for Dr. Agatston, and anybody else might have some additional information. Let me start with the first one. Do you often recommend or know or can comment on supplementation with some combination of calcium, vitamin D, and or vitamin K on calcium score and the deposition of calcium, how it affects the lesions and the progression, et cetera?
Yeah, not specifically for calcium score, and also getting rid of calcium, it's, you know, that's already a healed plaque. You want to stop new plaques from coming up. And as far as, you know, the only supplements, we measure omega-3 levels, RBC percent omega-3, and most of the controversy around omega-3 is from some very, very bad studies where they weren't measuring omega-3, and who knew, you know, low doses of omega-3 when they gave it to them, and who knew what they were really taking if you weren't measuring that. So I think the data is overwhelming in favor of us having Japanese levels of omega-3 between 8 and 12. Most Americans are well below that, and there's a lot of, you know, myths about that. The other thing we see, you know, all the time is not enough salt, particularly the keto flu is not hypoglycemia, it's dehydration because your insulin levels are coming down, and it's a good sign. And magnesium, where people you know, often are having cramps and are helped with magnesium, and so that's the main thing we're adding. There's no supplement other than omega-3 that will specifically decrease your chance of having events. Vitamin D is, as far as correlation, correlates with everything everybody says it is, but it may just be a marker for getting enough sunlight. One thing I like to quote is people who have basal and squamous cell carcinomas live longer than people who don't. And it's not that that's good for you, it's a marker for being outside and getting real vitamin D. And other than with COVID, we recommend, you know, some vitamin D supplementation, or if it's really low. But getting out during the day, not if you're in South Florida, not midday, but getting out in plenty of sun, I think is better.
I would just add, and obviously you'll be able to comment on this more, we really don't have any data showing that you need to reverse or lower CAC scores. There's no, you avoid just as many events if you stabilize your CAC score, presumably as if you lower. I mean, we don't have data because no one has really lowered CAC scores in large numbers.
You don't. If anybody who sees, I've been doing this a long time, I've never seen a calcified lesion disappear except for a technical reason. It doesn't, because it's healed. There's no reason to decrease your CAC score. What you want to do is not have new lesions because you've stopped those cholesterol pimples, and so that's what you're after.
Yeah, and so that just comes back to stop doing the damage that led to your CAC score going up in the first place. And in general, my take on supplements is stop doing the damage first. You're not going to supplement your way out of a bad diet. They shouldn't be used as a substitute for most things. You should really be able to get all the things you need from a proper human diet, and supplements should have a limited application after that if there's some measurable deficiency in something.
Agree.
Yeah, I would just add in terms of the vitamin D thing, it is a negative acute phase reactant. That means when inflammation goes up, it's driven lower out of the serum. So that could also contribute to low levels, in which case it kind of reiterates the stop doing the damage thing. But then in terms of supplementation generally, my view on it, if anyone cares, is that if you have made all the proper steps towards making a better diet, there are some cases in which you're in this healing phase for a while and you may need additional, or there could be conditions where you need to just supplement for a little bit if you have a deficiency. I'm in that scenario. I need to supplement folate. It is what it is.
Dr. Agatston, do we know what supplement all the Japanese take to get such great omega-3 levels? That's a setup.
Yes. But I don't think it's the sweet potatoes. So I think it's probably the amount of fish, but if for people who don't like fish, the omega-3 oil is not the mercury and all the bad stuff in fish is in the protein. So it's kind of a unique supplement in that it doesn't have a lot of toxicity, and we see the levels go up. So that's really the only supplement that we recommend.
Yeah, I'd also add in terms of the omega-3 thing, Amber has a talk from CarnivoreCon 2019 in which she pointed out that ketogenic metabolism can increase omega-3 levels in the blood. I've seen that in myself. I don't eat fish or brain very often, but I just did a fatty acid balance test after 4 years and change on a carnivorous diet, and my levels were in the optimum range for whatever that's worth. So it may be another case of just measure it, see where you're at.
Thank you very much.
All right, this may have been in the slides about COVID that Mark did not share. We know that people who are metabolically healthy fare better with a COVID infection than those who are not metabolically healthy. We're also in a phase of COVID that virtually everyone's going to be exposed to it and get it at some point. It's just where we are. What are your thoughts on, immediately post-COVID and then, the following months? Do you think about a more aggressive lower carb approach, a little more balanced? What are your thoughts on treating long COVID nutritionally, and how do you kind of scale soon thereafter and then in the subsequent months to get back to a good metabolic state if for people who are not, and for people who are in that immediate infection period where thinking about metabolic health is not what they're thinking about during the days or weeks that they're really fighting hard? How do you think about getting back into balance and treating it with food as best possible?
Go ahead.
I'll try and keep us from getting kicked off YouTube and just say, I think ultimately, COVID should be that wake-up call, and can be that wake-up call for a lot of people, that if you had a bad bout of COVID, it likely indicates that you're not metabolically healthy, and this is your chance to get metabolically healthy, and therapeutic carbohydrate restriction is a great way to do that.
And, let me just say, the risk factors for COVID, age is a marker for insulin resistance, beta cell dysfunction, obesity, which not all people who are overweight are metabolically sick, but the majority in this country are. So age and obesity are just markers, and you don't have to be obese to be metabolically sick. Diabetes, we know that depresses immunity, but so does insulin resistance, beta cell dysfunction before you're diabetic, also depresses. There are studies on that. And high blood pressure, they say it's mild high blood pressure. One of my subspecialties before was echocardiography. In mild hypertension, you don't see changes in vessels. It's a marker of high insulin levels. So all of the popular risk factors for COVID, all four are just saying you have a metabolic problem.
And I'd just add to that that high insulin is itself a marker of an overtaxed immune system.
Yeah, definitely encourage people to just read some of the references, but having metabolic syndrome increases your odds of having, they call it PAX, post-acute COVID syndrome, and we don't fully know what that is. It's like post-Lyme, but Delta was very damaging to the lungs, very vascular also. So we're going to see different things now with different variants, but it is the wake-up call like that Nina and I wrote that article a year and a half about. We don't know. There's PAX clinics now being opened around the country trying to learn what this is and what to do. So maybe in a couple years we'll have better interventions other than the common things we're saying now, get your sleep, gradually recover your aerobic fitness. It's basically rehab right now. And then if you've got a lot of vascular injury, it's going to take a long time for that to heal, I've got a number of people who come to my clinic, with long haul COVID, and we're looking up things together. I've put some on fluvoxamine, there's the antidepressant being used. There's no downside. We'll play with some of this stuff that they'll find, that's being used around the world, some vitamin therapies. But I don't know. That's a hard question. It's so unique.
Thank you.
I'll also just add that you can be on a ketogenic diet even long term and still be struggling with health issues. I definitely don't want to place blame on anyone for getting sick or leave that impression. Just take care of yourself would be my request.
I agree with Dr. Berry that this has to be a grassroots movement. I honestly believe I came to this community through my neighbor who I saw had great success. After not seeing him for about 3 months, he came back almost 100 pounds lighter. And I find that people ask me, I'm now 80 pounds lighter, they ask me, what'd you do? And they're anxious to hear information. And what I think the best strategy is to keep things very simple. And that's why I typically send them to YouTube to watch Dr. Berry's videos, because it's important that we understand that most people are not going to sit there and try to educate themselves on the Krebs cycle or any of these things. So my question is there some degree of celebrity that guys like you have to attain to be able to reach these masses? And how do you balance that with trying to be like medical, give medical facts, but yet be entertaining enough to keep people's attention and drive them in your direction? And I was specifically pointing at you.
About 4 years ago, I came home from the clinic one day, and Nisha said, how many patients did you take care of today? And I said, I don't know, 35. She's like, that's great, I'm proud of you. What if you could have helped 3,500 people? And I'm like, well, no, it would have been a hellacious day, right? But she's like, you should start a YouTube channel. And when she first mentioned that, I'm like, that's stupid. I am a board certified fellow. I am not, what are you talking about? I'm a doctor, right? And so we had a little skirmish about that, which I thought I won, but obviously I did not. And so, but she planted a seed in my head, which is what you do when you help people, is you plant that little seed. And the more I thought about that, the more I thought, you know, my job is to help people improve their health. That's my job. And then by extension, shouldn't I want to help as many people as possible improve their health, right? So I came home one day, I'm like, okay, fine, you're right, I'm going to start a YouTube channel. And so I started doing that. And so on YouTube, anytime you want to go viral and get very popular and get lots of views, you talk about apple cider vinegar. You talk either positive or negative, doesn't matter, you're going to get 1 million views. Vitamin D. What are some other ones? Like just foolishness, right? But people, I don't know, it's something, oh, you can talk bad about bananas, you'll get 1 million views every time. Stuff like that. And so you see gurus out there who have 47 videos about apple cider vinegar. Drink 1 cup of this a day and you will melt away whatever it is you want to melt away. And so it is a very fine line between being an entertainer and being an educator. And I think you do have to be entertaining to some degree. You can't be just boring as hell, or people are not going to listen and they're going to click off. But at the same time, I think we have a duty, all of us that are on social media, to try to be entertaining, try to be funny, try to be cute, whatever. But at the same time, when they're done with your video, you better have given them some information that is true and that is actionable. Okay, Stan Ekberg, love this guy on YouTube. He had a video where he just went through and talked about all the videos. 1 teaspoon of this a day to melt fat overnight. You know, drink this at bedtime and you'll turn into Marilyn Monroe, whatever. But that people don't have a clue about medicine or nutrition. They have no clue. They've been so misled by big food, big medicine, big pharma for the last 50 years that they are truly ignorant of just the basics of human physiology and nutrition. And so that's every video I make, I pretend that I'm talking to one person. It's me and you, we're in my clinic, and you've asked me a question about gout or about fibroids or about whatever, and then we have a conversation about that. And in that, I try to give every useful nugget I can, and then I always try to put resources, citations in the show notes, so that for the people who are like, Barry's full of shit, I can be like, there's the citations, right? Go look it up. But it's very tempting on social media to want to get 1 million views. You want to get all the clicks. You want to get all the thumbs. But at the same time, especially as a healthcare provider, there's a line that you cannot cross and get into, stick 2 peanuts a day up your butt and you too will have, grow hair again. That's 1 million views, by the way. If I made that video, 100%, that would go viral. Stick these 2 things up your butt and you can have a full head of hair. That's 10 million views right there. But you see my point, I can't be about that. I've got to be given the information that somebody can, as soon as the video's over, they can put it into action. And then not only that, but then a week later or a month later, see a result from the action. And I like to think that's where my growth came from. And I don't consider myself a celebrity by any means. I'm just a country boy who won't shut the hell up. And if I know something that I think that's going to help other people, I'm going to run my mouth.
This is a really serious skill, though. Not everybody can do what you do. And try not to be boring as hell. Well, I've been talking about carnivore diet since 2012, and nobody gave me 10 million views. So I could learn from you.
I have watched every single one of your videos, most of them more than once.
Oh, well, thank you.
Agatston, you need a YouTube channel.
I'm sorry, what? YouTube channel?
Can you show slides on his
This
panel?
is really my first time meeting all of you in person. But I've met you all on YouTube and social media, and it wasn't like that before. With our first books, you know, the Today Show, all that stuff, and you know, more people see you eventually on YouTube, and then end up coming to our practice. And if it's my practice, they may have seen me, but they've seen all of you, and they quote you. And I think there's a real difference in the paradigm of how people are getting educated. And instead of from a trashy newspaper, they find out the people who give real information and everybody else. And Amber, I probably heard more of yours than sorry for everybody else here, but in fact, I think I met Ben was via YouTube the first time, and he's, you know, part of our practice, and I send his videos. But I think it's paradigm changing, and I think that's the future and the best way to get the word out. Being on TV today, forget it. I mean, nobody watches, especially young people.
I'm so old school that I was having a Zoom meeting and somebody asked me if I was on YouTube, right? And I said, geez, I don't really know if I am. So and that was an honest answer. I had no idea if I was on YouTube or not. And so one of the guys on the Zoom went on YouTube. He said, Ben, you have 52 videos on YouTube. I had no friggin' idea what that was.
I know they're out there.
Yeah, that's my wife. That's my wife knows all that they're out there. But, oh God, that's funny. But you know what I'd like to do, because I don't know how many more minutes we have left. I always like to leave. You know, what do you want to leave with people? What's the takeaway from what we present, right? So if we could at some point leave 4 or 5 minutes and 1 or 2 lines from each of us, what's the takeaway? What do I want to leave you with? Just a thought, a concept.
Yeah. Okay. Well, let's start with that then. Let's do that now. Let's get us to.
I'll start because this is what I mean. Okay. One of my coaches when I was a kid, and I was dedicated and I wanted to work and all that, told me this, and I've kept it with me my whole life. This is 60 some odd years. Anything worth achieving is on the other side of comfort.
I think I had it in my slide. Just be kind and have integrity.
It's a horrible question, Ben. It's so hard. So I'll just flip it on you and I'll say anything that doesn't make you feel good isn't worth doing.
Well, I hate to bring up YouTube again, but the great thing is some lectures that I miss, whatever, no big deal. I can see them, and if I like it, I can see it 10 times. And so keep educating yourself, and there's just great education now on YouTube and social media.
I think the overall feeling that this conference has left me with, as it does every time, is that there is hope, and that applies to lipedema too. You don't have to just sit around and suffer and feel alone, regardless of what you're trying to work on. There is a community that can help you, and just reach out to them and ask, and we're here for you.
I would just say, don't accept that poor health is the only answer. Keep asking if you're not getting the answers you need to get healthy.
Yeah, 3 things. Number 1, there is absolutely hope. And I stole that, but yes, 100% there's hope. Number 2, the good health that you're looking for, there is a path to that is not complicated, that is not expensive, that does not require you to buy lots of pharmaceuticals or supplements or programs. And then thirdly, the default state of the human body is good health. That's the default state. Just like every other mammal on the planet, if you are not poisoning them with their diet or with their environment or with their lifestyle, they're just healthy. And that is true for us as well, unless we have toxins in our system from the food we've eaten or the clothes we've worn or the containers we prepared our food in or the environment that we live in or the stress that we endure that's not ancestral at all, or the situations we put ourselves in. When you remove all the toxins of all kinds from your life, your body will start to just naturally revert back to at least some degree, back to good health. Maybe not back to where you're just perfection, but you're gonna get healthier if you do those things. And it doesn't have to be expensive or hard.
I'm gonna have to ask you to restate that in 1 or 2 sentences per the prompt.
Well, that actually went a bit quicker than I thought it would. So we've got a few minutes. Have you got one question from the peanut gallery? Oh, sorry. They get offended when I make fun of them. Tell them I'm sorry.
You just did. Are you saying 5 minutes?
Yeah.
Okay, don't know if I want to go into the weeds of the hyper responders, but
Come, don't use up all your minutes.
we can go back to the panel again. Somebody asked if you could talk about one particular case that stood out to each of you where you really made a difference and it's been a lasting memory.
Yeah. Oh, let's go this way this time. Okay, so I had a patient who I'd seen for years, and then I got fat and sick, fixed myself, and he was a local preacher and weighed about 450, give or take. He couldn't weigh on any bathroom scale. He had to go to the co-op and weigh. He was so overweight. And he came to me and said, "Doc, what'd you do?" Standard question after I got healthier, right? And so I told him, and he was on the schedule to have a knee replacement and was also looking into bariatric surgery very strongly. He said, "Well, okay, well, can I do that?" And I was like, "Yeah." And so I said, "Beef, butter, bacon, and eggs. Can you do?" And he's like, "I can eat." And I said, "You can eat as much as you want, often as you want. Come see me in a month. We'll see how you're doing." And so his knee surgery was in 2 months. So he comes back in a month, and he had lost a chunk of weight, some of that fluid, but some of that fat. But he said, "Doc, my knee doesn't hurt anymore." Still well over 400 pounds. He said, "My knee's not hurting at all." And they had x-rayed it, and they said it was bone on bone. How is it not hurting? And this was very early in my proper human diet career, so I honestly had no damn idea why his knee didn't hurt. Right? I didn't know if he was blowing smoke or if it was just, it just happened. Who knows? I don't know why. But he said, "Can I do this for another month?" And I'm like, "Yeah, let's live dangerous. Do it for another month." And so he comes back in a month and he's lost another chunk of weight. And he said, "I called the orthopedic surgeon and canceled that knee replacement." And he said, they said, "Well, yeah, if it's not hurting, you don't need it." And so he said, "If it starts hurting again, call us back." And he reached out to me on social media. This has been years ago, and he's a big guy, just like the former football player. He's just a thick, chunky hunk of a man, but he's lost all this weight, and all his metabolic markers are beautiful now, and he feels great. He walked with a cane when he first came to the clinic because of the knee. Never walks with a cane anymore. And he was the patient, and that was the moment when I went, I wonder if this keto shit does more than just weight loss. And that was really the epiphany for me that this is not just a temporary weight loss hack. I need to go back and look at the science on this, because this may be more important than just for weight loss.
So, for me, I would just say it was, a case with a bad outcome that, really opened my eyes. And this is the opening story in my book. And it's, a 40-year-old mother, who came in with just a devastating cardiac surgical problem. It's called an aortic dissection. It's kind of like the worst nightmare of every doctor. And despite, operating for 16 hours, we just couldn't save her. And it was at that moment that I realized, how we were failing all of these people. And that, the majority of the people that I have operated on in my career didn't need to be there. And that's what really opened my eyes to the power of this. That's why I'm here doing all of this now, and we just have to keep in mind how the medical system, our whole culture, our whole healthcare system is failing so many people.
I don't know that I have any cases exactly because I don't have patients or anything like that. But one thing that's been on my mind recently is someone had reached out to me on Twitter, and I've mentioned this a little while ago, but they had a long-term weight loss stall, so they lost a little bit of weight, and then they had been stalled in weight for 2 years. But more importantly to them, they had persistent hunger and obsessive thoughts about food. Even on a ketogenic diet, they had tried a whole bunch of different things within that realm, and it just wasn't working. And they had been working with someone else, and they were told, hey, why don't you try high-fat carnivore? You haven't tried it yet. So they had reached out to me, and I was like, let me call you. We got to talk about this. So we talked for like an hour or two, and they've been sending me updates since they've been doing that, and they've been consistently losing weight. Their obsessive thoughts about food are gone. Their constant hunger is gone, and they're losing inches. Like everything is going in the right direction, and their insulin is coming down, which it hadn't before. And I'm just really happy for them. So that's what I've been thinking about.
Well, with this overall approach, the number of really amazing cases we see in our practice, including our internists, is incredible. But one, in the early days of our low-carb South Beach diet, we had the first phase, and people always wanted to stay on it, which I thought that because it's a fast weight loss, and don't quite believe in phases anymore, or a bunch of other things we wrote at the time. But people just felt better. Their skin cleared up, and their arthritis improved, and all these other things, which I was very happy to take credit for, but I didn't know what was going on. But one of the most dramatic cases was a woman who was overweight, went on the diet, and had been trying to become pregnant for at least 7 years unsuccessfully, and all of a sudden became pregnant, which again, I was very happy to take credit for, but I had no idea what was going on. And until later, this is in the 90s, so I read about polycystic ovary disease and treating it actually with metformin, and I said, oh my God, that must have been what happened. But we followed her for at least when the new baby was 12. So as far as a dramatic case, I wish at the time I really knew it was due to our diet, but that was one of the more dramatic cases.
I'm going to politely decline this question because I have no patience, and the only stories that have been really inspiring to me have been ones that come from that they aren't my story, or they are so close to me that I wouldn't really feel comfortable revealing them. So I'll pass it to Mark.
I have some just from this week on the slides. Didn't get, like Arthur, too many slides. But we have these things called well-person ceremonies when they actually are off all medicine and their stuff's all normal. So I actually saw a patient that we admitted like 3 years ago. He was in his mid-30s, fully diabetic, and he had massive PEs. And he was like mid-300s. And about a year ago, I hadn't seen him in clinic for about a year because we had done his well-person ceremony, so he's good. He doesn't need to see me. And he walked into my running store, and he needed some new shoes, and still looked like $1 million. But that's like the holy grail. He just needs some new shoes. He's good.
I've been doing this 50 years, so I have hundreds of wonderful stories. People tell me I've changed their lives. And maybe one or two even for the better. So I had this one sticks out, a security guard in front of my house that works the gate. And he says, Doc, they told me I've got cirrhosis of liver. And this guy had, when you talk about abdominal fat, I could have stuck a Volkswagen in there. And I kept talking about it. He read my book, blah, blah, blah. Said I was leaving to go for two months to Coronado. And I got so mad at him because he's a nice man, a smart man, but he was just a mess. So I said to him in that nice New York kind of emotionally, affable way that I have, I said, I gave him Westman's book, and Westman has the 1 page that says, you eat this, this is it. You don't eat anything else. I said, I want you to do this, and in 60 days I'm going to come back. And in my empathetic way, I said, if you don't lose 60 pounds, I'm going to beat the shit out of you. All right? When I came back, that guy's head shrunk. I mean, everything on that guy's body shrunk, and he says, Doc, they don't think I have cirrhosis anymore. That was cool.